Dr. Vikram Muthusubramanian is at present, he did his MBBS from Siddhartha Medical College, Tumkur, and M.ch from VHS, Chennai, and a fellowship, underwent a fellowship in functional neurosurgery involving deep brain stimulation, epilepsy surgery, spasticity, and brain therapy under the guidance of Dr. Paresh Joshi at Jaslok Hospital, Mumbai. Minimally invasive spine surgical techniques like foraminoscopy, percutaneous pedicle screws to fixation under the guidance of Satish Chandra Gaur, Pune. And 16 years of experience. His clinical practice involves more than 3,000 cases of various neurosurgical procedures like minimal invasive spine surgery in cervical and lumbar endoscopy, neuroendoscopic approaches involving intraventricular tumor removal, CSF diversion procedures like endoscopic third ventriculostomy, skull base and extended transnasal endoscopic surgery, functional neurosurgical procedures, baclofen pump for spasticity, temporal and extratemporal epilepsy surgery. At present, he is working as the senior consultant neurosurgeon at Ramakrishna Hospital in Coimbatore. I welcome Dr. Vikram sir to give his lecture.
Good evening, everybody. It's nice to see all of you over here, and I'll come to the topic right away. Hope the slides are visible, sir.
Yes, sir.
Rajesh, sir.
Yes, it is visible, sir.
Yeah.
You are audible.
Thanks a lot. Just a minute. Neuroendoscopy needs a cavity, the telescope, and the light source. We have various endoscopic, the 0-degree scope for transnasal endoscopy, 25-degree scope for spine, and 6-degree scope for brain endoscopy, and 25-degree scope with a larger diameter for foraminoscopy. However, for tumor surgeries, mainly except the foraminoscopy scope, all the rest are being used. My journey into the neuroendoscopy started with suprasellar arachnoid cyst with bobble-head bowel movements in VHS, where repeated shunt failed, and finally we had to land up in third ventriculostomy and placement of the shunt tube into the cyst, with which the child improved. This is the post-op scan. And we all know where intraventricular tumors, the standard what we use is the neuroendoscope when there is a hydrocephalus along with the colloid cyst due to obstruction. And we all know the colloid cyst, how it is removed. However, let me show you just a case example, which is a septal colloid cyst, which is a bit larger and involving into the septum as well. These are the CT and MRI images. And as we introduce the endoscope, we can see the septum, which is because of hydrocephalus have multiple septations as well. And the septum is ballooned. Even the foramen of Monro is obstructed because of the ballooning of the septum itself. So the access was first we made to opposite ventricle also, through made a perforation through the septum for communicating the ventricles, and we can see the ballooned out septum, which is being coagulated with a bipolar cautery. and there will be always some ooze, which many a time will get stopped either with the bipolar coagulation or even just saline irrigation of warm saline and waiting for some time with the closed intraventricular CSF locking, where we don't let out the CSF. When the pressure increases, automatically this capillary stops, and there through the septum we can see the wall of the colloid cyst. Just making a small entry into the wall of the colloid cyst. You can see the colloidal content coming out into the ventricle. Generally, many a time when the colloid cyst is projecting directly into the foramen of Monro, we try to bring the colloid cyst into one of the ventricles and evacuate the content and then dissect the capsule. Here, that because that choroid plexus is dense and we are not able to see the foramen of Monro itself, we made the decompression through the septum, and as we are decompressing, we can observe that the foramen of Monro is getting opened up, and we are gently dissecting out the capsule. So that's the capsule. Most of the time there will be some attachments of choroid plexus to the capsule. As we gently dissect, pull, leave it, and pull, as we don't have the bimanual control in this endoscopic system, we can even cauterize the surface and partly coagulate the choroid plexus to decrease the vascularity and the bleeding. So as the capsule is dissected, is gently pulled, and the capsule along with its content has been removed by gentle dissection of this way. The ooze was controlled with closing of the intraventricular CSF outflow, whereby the CSF pressure increases and the coagulation occurs. So there were few clots. I have personally designed a long suction tip way back in 2007 or 8 when I bought the endoscopy system, which is our regular suction with extraordinary length, so that you can control at the same time have a multiple holes in the suction tube, which helps us to control the suction pressure. So this is the post-op CT showing complete excision of the colloid cyst. There were few clots here and there, but most of them generally resolved. Though I leave a EVD, I don't keep it open. Most of the time it's as an emergency. But on the day 2 or day 3, when the patient is up and about, we remove the EVD after a CT scan. So this is another patient with cystic lesion in the floor of the third ventricle. Similarly, the lesion was removed, and this happened to be a hydatid cyst. And this is a patient who came with the hydrocephalus. I think some of you would have seen this video before. There is hydrocephalus, but ill-defined membrane-like things in the third ventricle, which was floating. This is as we enter the third ventricle. That's the mammillary body with the flow. You can see the floating membrane, which is a arachnoid cyst. because it is floating, it was partially obstructing the flow on and off, and causing the hydrocephalus and its symptoms. So to be on safer side, I did the endoscopic third ventriculostomy to give the CSF diversion, which is as standard as everybody does it, opening the membrane and then dilating it, followed by this has a huge venous channel along with it on its surface, and so I was not sure whether excising it will cause some thalamic infarct or whatever. So that's the fourth ventricle, aqueduct of the fourth ventricle. So in having such a big vein, so I decided to shrink the arachnoid membrane instead of excising it, using the bipolar cautery, periodically shrinking the surface of the arachnoid cyst. As it is floating, we have to be dynamic. Most of the time, I don't fix the endoscope because the frequent movement gives us the three-dimensional depth, and micro movements helps us to have better control and more visualization. So periodically cauterized, even some of the choroid plexus need to be cauterized. So the huge advantage of using the bipolar endoscopic bipolar helps us to have a good control without much problem. And close to the end, it was shrunk and the ventricle was left or without any obstruction. So apart from intraventricular work, this is a patient who I had operated for trigeminal neuralgia, that is endoscopic assisted neurosurgery, and most of my patients I do it awake, and even the endoscopic procedure for trigeminal neuralgia I was able to do it awake, thanks to the present era of medications which helps us to do it more comfortably. The advantage of doing it awake for me is at the end of the procedure, we know immediately the patient is absolutely relieved of his pain. In a few cases, I did had partial relief. So when we searched for the offending vessel, we were able to find another vessel in those cases and complete the dissection and do a decompression adequately with the placement of Teflon, so that patient has complete relief of pain. So that's the decompressed root. And most of the time I do place some amount of gel foam close to the roots. So this is a patient who presented with another arachnoid cyst and hydrocephalus. So this patient again underwent third ventriculostomy and perforation of the cyst capsule to communicate. And this is a patient post tuberculous meningitis, had porencephalic kind of cyst, trapped ventricle. This again required endoscopic fenestration. This is another case with which required endoscopic fenestration because of loculated cyst. So this is the patient who had another arachnoid cyst with obstruction of the aqueduct. So we did third ventriculostomy and cystoventriculostomy, whereby the cyst was communicated into the ventricle and ventricle was communicated to the base of the cistern, establishing the CSF pathway and relieving the obstruction. So that is just posterior to the aqueduct, the capsule, which was cauterized with the bipolar. And the flow was established. So that's the third ventriculostomy which was performed and it's pulsating very well. These are the post-op scans which shows significant reduction of the size of the hydrocephalus and patient became asymptomatic. This is a pineal region cyst which was excised endoscopically. Sorry, I couldn't edit the video for it. This is another arachnoid cyst child with hydrocephalus, required endoscopic ventriculostomy to the cystoventriculostomy. So this is a patient with the post-tuberculous meningitis with trapping of the foramen of Monro. The foramen of Monro was opened out, and you can see the ventricle was fully studded with small tubercles, which was biopsied and was confirmed to be a tuberculous origin. This is a child with the choroid plexus papilloma. Here we use the endoscope to partially cauterize the vascular pedicle and devascularize the papilloma, followed by excision by a small craniotomy through the cortical surface through ulcers. So this is a patient who came with large epidermoid extending from the pineal region and mostly extending into one side of the ventricle. So this is the position, the 3/4 bone position I adopted and approached through the right side of the supracerebellar approach. And after adequate excision of the supracerebellar portion, we use the endoscope to inspect the cavity. Sorry, I am unable to. So this is, these are the ventricle with the choroid plexus and small residual portions of the epidermoid are removed with the help of endoscope. These portions were not visible when we were trying to visualize through the microscope because of the acute angle and anterior to the cerebellum. In the depth, we are unable to visualize, but with the help of endoscope, we could visualize it and remove it. Those are the peduncles of the brainstem. So that is the venous confluence which you are seeing at the 12 o'clock position. Both vein of Rosenthal, internal cerebral vein, and they are draining into the vein of Galen. So this is a post-op incision and patient. And these are the post-op scans which shows total removal of the tumor. This is a patient who came with back pain and there was intradural lesion. Because of root irritation, the patient was having radicular pain as well. So this is excision of the tumor through using the tubular retractor system. On your left is the cranial side, on the right the caudal, and to my on inferiorly is the left side, and right side is the superior aspect, 12 o'clock position. This is after laminectomy. Ligamentum flavums removed, widened. This is more similar to how we do a hemi or quadrilaminectomy and removal of the tumor, except we use the tubular retractor to minimize the extent of muscle dissection and damage to the muscles. So dura is incised as usual, extended. Further extension relieves the pressure on the roots. On gentle dissection, we use a little bit of coaxial instruments to do the same procedure what we do it when we are doing in the standard hemilaminectomy or laminectomy exposure system. So the roots are dissected, the lesion identified, capsule identified, capsule superior pole and inferior pole delineated. As the tumor was not moving, after dissection, debulking started. After adequate debulking, the capsule dissected all around. Tumor excised in piecemeal along with the capsule, and this happened to be a meningioma with its attachment to the dural sac. After excising the dura, the endoscope was 0-degree endoscope was introduced inside to verify adequate complete excision. The dura approximated. Few cases I use Liga clips. Here I directly place the DuraGen and sealed it, covered with gel foam and fibrin glue. And there is significant muscle layer. Hardly we get any leak. This is the post-op MRI showing complete excision. And I just concentrated on getting some tidbits of all varieties of cases, excluding transnasal endoscopy, which is as such is a separate big chapter to follow on. Thank you. Thanks a lot.
Vikram, that was an excellent presentation. So your videos were very good. You will open the colloid cyst and evacuate the content. Is there any risk of chemical meningitis due to the spillage into the ventricle?
Sir, so far I have not had any case of chemical meningitis. Most of the time our suction is taken into the colloid cyst and we suck it from there directly. So the contamination of the material into the CSF is very less. It directly gets sucked into the suction tip and comes out. Because of it is being viscid, it doesn't get diluted that faster.
So do you use any steroids or any steroid wash or post-op steroid, thinking that there may be a chemical meningitis later?
No, sir. Actually, when we are irrigating the ventricle throughout the procedure, most of the CSF washes off, and what is left over is very less inside. And even after the procedure, we give warm water saline wash for some time so that all these particles comes out. So that may be one reason also for less chemical being left over inside the ventricle.
Because we use steroid for epidermoid surgeries. Steroid was during the thing. It's the same principle used in the colloid cyst also. I'm just wanted to know. That's
So far, I have not used, and definitely most of the time we also use the steroid, both IV and wash, as soon as we open up the arachnoid around the epidermoids. Definitely.
Can you hear me?
Yes, sir.
Vikram, nice presentation. What is a general incidence of recurrence of colloid cyst after endoscopic removal or in your series, both?
In my series, I have not had any recurrence, sir, so far.
Overall, what is
a few cases of clots retaining for a little longer time, and ventricles took 3-4 days more to reduce in its size. Other than that, the chance of recurrence, I have not had any recurrence. But even in one of the meetings, the CMC people were also saying that even if you remove the colloid cyst with the capsule, you may leave some small capsule tidbits in the around the choroid plexus. But the natural course of the disease of colloid to grow itself is very slow. So probably to see a recurrence, we may need at least 20 to 30 years of observation. So we don't, personally, I don't have that many years of observation to say I had not had any recurrence so far. But touch wood, so far I had not had recurrence, probably for the past 15 years.
Second thing, when the patient, most of the patient present to us colloid cyst with a headache, but not a typical headache. When you took an MRI, colloid cyst is there. How do you attribute that?
Speakers, kindly unmute yourself and speak, sir.
Now it's okay? Okay.
Yes, sir. Yes.
Most of the colloid cyst patient present with a headache, we take an MRI, colloid cyst is there. How do you attribute that headache exactly to colloid cyst clinically?
Many of the colloid cysts are picked up incidentally.
Yeah.
Even after head injury cases, we have picked up quite a few number of colloid cysts. If we go by the history, except if they have a positional headache and then it relieves on its own, which is commonly seen with the colloid cyst when it is floating. Other than that, it's very difficult to predict based on headache alone. But most of the other symptoms pops up when the hydrocephalus is fully blown.
Spinal tumor you showed, Vikram. How did you close the dura? Did you use sutures or
No,
just
sir,
apply the Duragen?
In this case, I applied Duragen directly. But if you have 4-0-proline and that small needle with the same needle holder, like what we have used it for holding the tumor forceps, we can close the dura primarily also, but it will take little longer time. That's one. Another way of closing is using the laparoscopic mini Liga clips. You pick up the dura, pull it towards you, and then apply the mini Liga clips, which is another way of approximating and closing.
With the tubular retractor, manual closure may be a little difficult, isn't it?
In the tubular retractor, we have 3 sizes, sir. So for a fat person, definitely when the length is more, we will have little difficulty. We need that coordination practice little more. But when the tubular retractors are small for a thin patient, it's not that difficult. Even our regular spinal closing needle holder can be used in that case. Only when the retractor length increases, we have the difficulty.
No, is that mini Liga clips works well? Is it possible for us to use in other situations also?
Mini Liga clip, if you pull both the dura closer, dural margins closer and apply, it works well.
Can we use even in open surgeries in thing, because sometimes maybe time consuming or some dural tear during any MLD, is it useful?
I think we can use it definitely. Won't be
Okay.
a problem. Only thing, we have to pull the dura. Otherwise, roots can get entrapped.
Okay.
So once you pull the dura towards you, the chances of root getting entrapped is very less.
So what I'm asking, is it a different instrument we have to use, or it's like our regular
So
Liga
most
clip?
of the laparoscopic people have this mini Liga clip for the
But we have to use the laparoscopic instrument.
Yeah, our most of our gastroenterology people will have that mini Liga clip system, which is a disposable, and the clip applicator is same. The clips are disposable.
Okay.
So we can use the same thing over here. I hadn't recorded that. Next time when I record it, I'll put it forward. That when you see it, it will be easier to understand.
Yeah, sometimes when we do MLD or something, of course, occasionally.
Any dural tear for that matter.
So it will be useful, no, instead of using it.
And the same Liga clips we do use when we are opening close to the sinus. If we get some sinus wounds, the way we are suturing, instead of suturing, we can apply the same Liga clips also.
How do you, I don't know, just I'm asking curious, you know, preoperatively that is meningioma. Still you are comfortable in going with the tubular retractor and with what is that, the new technology like endoscopy? Is it you decide on the size or?
It was on the lumbar side. So I was sure that we will not give more trouble to the patient. If it is a neurofibroma present posteriorly in the dorsal, we can boldly approach. If it is a meningioma in the dorsal side, we have more chance of retracting the cord and we have trouble. There, I would definitely say preferable to go by standard method, because we will have wide opening. This is on the lumbar side, and being a small size, and most of the time these tumors which we try to do it in tubular has to be one segment, that is L4 level, L5 level, things like that. If it is crossing two segments, we won't be able to have the access that comfortably. There will be hidden space which we can't see. For that, better to go by the standard method itself.
The another thing for an MBD, you know, what kind of position you use the 3-pin things and lateral position, or
generally in MBD, most of the time I'm doing only awake recently.
yeah, that's what I'm telling awake. What is the position?
I don't put them on 3-pin. Only the head gel rest, because putting them on 3-pin and fully conscious, they become restless after some time, even though if we give scalp lac. However, even with this, I give a scalp lac and liberal infiltration with diluted xylocaine, dexa, and sensorkine, so that the pain is less. And the present Dexmed Fenta propofol mixer, when I am doing the craniotomy, the patient is kept completely sedated. So as soon as we are trying to open the dura, the patient is started to be awakened. And I have not faced any major problem. 1 or 2 times patient had minimally moved, but most of the time they keep awake and they are very cooperative, and instantly we see the pain is relieved.
Yeah, in that part, I am better to differ, because you see, in tumor surgeries an eloquent area, okay, we are using awake procedures to know the language area or a motor area. In trigeminal neurology, you don't get 24 hours trigeminal neuralgia. The patient will get pain on and off. So how can we decide that once we relieve that compression, patient gets relieved of the pain immediately? That is the bit of our assumption. You see, you don't get the patient 24 hours pain once you remove
Most of the patients which we are taking up for surgery have resistant pain. Even after multiple drugs, they are not responding to pain. Only those cases we are taking up for surgery. And in those cases, when they are on pain, when we are operating, and I have personally seen most of them get instant relief.
No, that's I accept, because post-operatively we have seen that patient don't have
And
a pain.
none of patients had the post-op pain also.
Yeah,
None of them had recurred. So this gives, and 2 or 3 cases probably, I can say, definitely after one loop removed, they persistently had pain. So I was looking for another loop. It was there, and removal of, dissection of that loop did relieve the pain.
no, it's a good thing if that is helps, means everybody can use that. The second thing, you use IONM for the trigeminal neuralgia.
No, I have not used IONM because the blink reflex system is bit tricky, and I don't have a neurophysiologist who monitors for me. I have been using only our EEG technician who are well versed with using the intraoperative neuromonitoring, and she got trained somehow with the multiple procedures, and she went to somewhere and then got some training and also came. So with that we are working on. So blink one, she is also not confident, and so we are not using that.
I don't know, maybe I have to try the awake procedure once. I don't know, because it's a bit of cumbersome.
Yeah, 1 or 2 cases you do, then you know the benefit of it. And
Like,
one thing what I observed, as even when we are doing under GA, when we are dissecting the root, we will have that brady. So that brady even comes here. So our anesthetist, after a few cases, what he started doing is, just before dissection, he gives a little bit of what is it? Atropine analogs, so that it sustains its tachy, so that they are not afraid of. Sometimes it comes even down to 30, 35, the heart rate will come. But after dissection, once the pain is subsided, the heart rate becomes normal. But now they have started, because of the low heart rate, they are afraid, and they started giving this atropine analogs to stabilize it. That helps us a lot not to have brady during the procedure.
do you experience hypertension after the procedure? Almost all the patient needs on antihypertensives IV in MBD.
So far, I have not had post-op hypertension exclusively. The patients who had hypertension pre-op,
Yeah, they will get relief.
Yeah.
Get relief, but post-operatively, sometimes hypertension and the giddiness, headache, all those things.
Headache they get, some numbness and headache they get. Probably I attribute to some amount of air which is accumulated in the supratentorial portion when we are releasing so much of CSF down. So I attributed that, and most of them subside over 3 to 4 days.
Thank you. Nice presentation. Thank you.
Thank you, sir. Thank you.
We don't have any other question. Can you proceed to next topic, sir? Murugan, sir.
Dr. Rajesh Babu, any quiz today?
Today, Vikram sir,
Sir,
you can ask any question, and you send a message to me, the answer, and we will award the winners from the talk which you gave. You can ask any of the questions and let the PGs answer.
yes, sir. I'll message.
1 or 2 questions. No, you just ask the question straight away, and the answer only you send it to me. We will analyze at the end of the program.
So let Dr. Vikram have time till end of your talk. Maybe he wants to decide on a good question.
Thank you,
From
sir.
your talk, you can decide.
Yes, sir. Thank you, sir.
Dr. Cody, will you take over?
Yes, sir. We'll move on to next topic. Naveen? Yes, the next topic is done by our Secretary, Dr. V. Rajesh Babu. First of all, he's a very dynamic, enthusiastic personality, and our Secretary only started the CME programs, and his perseverance towards these programs were excellent, and because of his continuous efforts,
These programs are continuously happening in France, and also used to follow up everyone to get the works done. And he's a senior neurosurgery consultant at Ganga Hospital and also president of IMA Coimbatore. He completed his MBBS in 1987, M.ch General Surgery in 1997, M.ch Neurosurgery in September 2001, and has been working as a consultant neurosurgeon in Ganga Hospital since 2010. So during his tenure, Ganga Hospital was awarded the Neurotrauma Institutional Award in 2017. Has been recipient of many national and state awards during his tenure at Ganga Hospital for his contributions in the field of neurosurgery and at various state and national medical associations. He is a founder member of Erode Neuro Foundation Trust and Erode Coimbatore Neurological Society. He was the organizing secretary of NSICon 2014, National Conference of NSI 2014, actively involved in conducting public awareness programs of head injury, epilepsy, organ donation, Alzheimer's disease, Parkinson's disease, stroke, and diabetic neuropathy, and periodic neuro update programs of practitioners of Coimbatore. We welcome you, sir. Dr. Rajesh Babu.
Naveen, please mute everybody.
Sir, done, sir.
My slides are visible?
Yes, sir.
Yes.
Visible.
Yes.
Yeah, visible. Yeah.
Before starting my talk, I want to show one video clipping which has been prepared by the IMA TamilNadu.
Dr. Rajesh, is there any audio for this video? Dr. Rajesh?
Sir, kindly unmute and speak, sir. Rajesh Babu, sir.
Navin, can you tell Dr. Rajesh to unmute the audio for this video?
Yes, sir. I'll tell, sir.
Hello.
Yeah, we are not hearing the audio that is accompanying this video.
I don't know why it is not coming.
Okay. No problem then.
Hmm?
No problem.
இப்போ வருதுங்களா?
இல்ல வரல.
இப்போ வருதுங்களா சார்?
இல்ல, there's no audio. We're only seeing the video.
I don't know why it is not coming.
No, it doesn't matter. You can just skip to the relevant portion of the video and then start your talk, where there are some sentences or something.
Good evening, everyone. Now I am audible?
Yes, sir.
Yeah, you are audible.
So, professional protection linked to social security scheme of IMA Tamil Nadu was inaugurated on April 26, 1998. And all the life members of the IMA Tamil Nadu state branch could be the members of the scheme. And in September 2001, they have created the family benefit scheme and a hospital protection scheme also started. PPLS office bearers will run these two schemes. PPLSS, the family benefit scheme, and a hospital protection scheme. What is the purpose of the PPLSS? See, from consultation chamber, doctor may be dragged to the court even of no fault of his. The commercialization has paved the way of consumerism. Insufficient communication has led to our own perils. Even experts have experienced trials. If a doctor received a notice, it will certainly wipe out all of his self-respect and self-esteem and will result in discouragement, depression, and despair. He will be eagerly looking for a support. To ask for help and to accept help is not demeaning. So asking for help is a right and therefore produces no disgrace and is no affront to dignity. PPLS scheme is for the doctors, of the doctors, and by the doctors. Early enrollment is the PPLS rescue doctors during crisis. Actually speaking, for example, now we have around 38,500 members in Indian Medical Association in Tamil Nadu, but we have only less number of people. Approximately around 10,000 people only are the members of the PPLS. Till 28,000 people have to become the members. It is a real pathetic situation. See, why PPLS? Recently, in Times of India, you might have seen on 9/5/2023, one gynecologist was asked to pay 22.9 lakh relief. That was one such case which you might have gone through, and they were not able to win. And this surgery was done under laparoscopy, and the patient died. That was the problem, and for that 22.9 lakh rupees was sued for that case. The procedure for the PPLS is in this: when one receives a notice from lawyer or consumer counsel, they are requested to immediately reply to that and deny all allegations, and detailed reply will be sent within 30 days from the PPLS office. Then they need to send a copy of the notice, case sheet, and their points regarding their subject to the legal committee chairman, and notice copy to the PPLS secretary. Then only the case will be taken up. And it is mandatory that a member must send a typed copy of the case sheet to the legal committee chairman, enabling him to start preparing the reply for the notice. There is no outside settlement as per the PPLS rules. The members can engage the PPLS recognized lawyers in that district, or they can engage their lawyer after informing the district coordinators. The district coordinator will consult the PPLS legal office and secretary office and then give consent to engage your lawyer to appear for the case in the particular district. After district forum judgment, if the case is lost and there is any amount to be deposited, the member will deposit the amount in the court as per the judgment. The PPLS will pay the lawyer's fee. The case will be appealed in the state forum. There are 2 PPLS lawyers for the state forum. They will take up the case and proceed. The deposit paid by the member in the district court will be reimbursed by the PPLS after the case over in the state forum. The judgment is received from the state forum. Depending on the state forum judgment, it will be decided whether to appeal to the national forum or not by the PPLSS office. When in routine cases, a complaint is given in a police station, the sub-inspector or inspector will call up for inquiry. In this situation, we must inform the branch president and secretary and then go to the police station and explain to them and come. After returning from the police station, the branch president and secretary must be informed. The district coordinator may be informed before going to the police station. And regarding the PPLS, the new membership fee, now is that what existing in Tamil Nadu is 10 lakhs for compensation for a block of 5 years and 20 lakhs for a compensation for 5 years. That is, you need to pay only once in 5 years. And it is divided into 3 categories. One is general practitioner, and another one is non-surgical, and another one is surgical anesthetist. So non-surgical is the persons, mainly the physicians only will come in that. Rest of the people all will be going to the surgical or anesthetist category. And the subscription is plus the 18% GST also added now. And for general practitioner, it is 8,200, and for 20 lakhs is 15,340. For the non-surgical, it is 9,440, and for 20 lakhs is 17,700. And for surgical anesthetist, 10,620, and the 20 lakhs is 20,060. The amount has to be taken in the form of the demand draft, and it is taken in the name of PPLS of IMA Tamil Nadu. Now the office is changed to Kumbakonam, payable at Kumbakonam now. And all our members of GPs, non-surgical specialists and surgical specialists, anesthetists can utilize these facilities. And it is 10 lakh and 20 lakh. That's all available for the legal advice. And when after the 5th year, when we are going to renewal it, and bonus eligible if renewable is without break, if no legal claim is made in the past years, they will be coming under the category of bonus. In that, the previous amount what I have shown is 8,260. Now it is 7,080. Like that, it reduces. The bonus is given and it is reducing. And even for surgical anesthetists, for 20 lakhs, it was 20,060. It was 18,880. That is approximately 2,000 rupees are getting reduced. And once after 5 years, they will be sending the form to the person who is to repay that. And from that, they see and they can pay the money. And from 1/4/2022 onwards, the PPLS members, there is a solatium is being given for the members in the event of death of the person. The family of the member will be provided with solatium of 50,000 each for a member who was less than 5 years in member in the scheme, and rupees 1 lakh for the member who are PPLS members for more than 5 years. It is like actually it is for the funeral fund, like they are telling. And the highlights in a nutshell is help you to counter CPC, and makes you to shed your defensive practice, best defense in the offensive society, coverage from the day one of the enrollment, guidance and safeguarding from day one of the receiving, and compensation for 5 years. Once in 5 years only, we need to pay. The main thing is, and the other thing is the hospital protection scheme. For our IMA members having nursing homes, they should become nursing home board members and then become the hospital protection scheme members. Nowadays, notices are sent against the hospitals also. The hospital protection scheme covers for 3 years. The scheme will take up notices in cases against the hospitals enrolled and pay the compensation awarded against the hospital, but not against the individual doctors. The hospitals are requested to ensure that all the consultant and duty doctors are enrolled as members of PPLS scheme, so that entire notice or case can be taken and fought collectively. The hospital should be members of IMA nursing home board. Actually, in our hospital, where I am working in the Ganga Hospital in Coimbatore, for the PPLS, our hospital itself is paying for the consultants actually for the PPLS. The same thing can be followed in most of the hospitals, and the hospital owners, we can request them and we can tell them this is an example. And in the hospital protection scheme, it is divided into primary, secondary, and tertiary level. Primary is without any extra facilities. If they are having a practice, a small nursing home, they are taken as primary and they need to pay 5,900 and 10,260. These are all the two things. And the secondary level, any one facility is included. For example, ICU, theater, labor room, X-ray, scan, or lab, any one facility they have, they need to pay 8,260. And that is for the secondary level 2 facilities, 11,800 and 23,600, and all 3 facilities, if it is available, like X-ray, the scan, and all those things, they need to pay 18,880. It is less than 50 beds hospital are coming into the secondary level, and tertiary level more than 50 beds, and they need to pay 64,900. The subscription amounts includes the GST, and it is to be taken in the time of hospital protection scheme. And renewal once in 3 years, they have to do it. The PPLS of IMA TamilNadu renewable account, they have to take. That is the thing. These are all the 2 things: the professional protection linked to social security scheme and the hospital protection scheme are the 2 schemes which are available to protect our practice. That is the main thing. And I request all the members who are attending here also to, if you are not member, please be the member of PPLS. And also the hospital which you are going, you ask them to become the members of the hospital HBS scheme, hospital protection scheme. When we are asking for the thing, people used to say, sir, in this only there are 20 lakhs only they are covering, but I have taken for 1 crore. But even if you take 1 crore in an insurance office, they will not reply anything. Everything we have to prepare and we have to do it. But in the PPLS, if you have a case, immediately you inform to the office after replying the query which was sent, and subsequently they will take care, and we can appoint the lawyers, and the lawyer fees, everything are straight away paid immediately. But in the private insurance, it is not like that. That is the difference between the PPLS and the professional indemnity scheme, which everyone used to talk. And another thing is, in the same, they have created a family benefit scheme. Family benefit scheme is nothing but a health insurance scheme actually. That is, the family benefit scheme is utilized by our members. It is like Mediclaim, 1,20,000 only per year coverage, and maximum 60,000 at a time, with a gap of 6 months. This is the yearly renewal. We need to do a yearly renewal like any other insurance, Mediclaim insurance. The scheme shall reimburse 1,20,000 for the hospitalization expenses incurred in that year for the member, spouse or children. It is a group policy like below 24 years and not exceeding 60,000 per hospitalization for the members or their nominees. The member has to inform the scheme office about the hospital or of his or her choice for elective surgery before admission. And the family benefit scheme is utilized by our members the same way, 1,20,000. Claim must be made within 60 days. Eligible to claim reimbursement for treatment had within Tamil Nadu. The interval between one claim to another is 120 days. And renewal of subscription without a break is essential. This is an example how much we need to pay. Up to 45 years, it is we need to pay 4,130, and 46 to 55 years, 5,310. Up to 65 years, it is 6,400. Like that, it is going on. But persons up to a age of 60 years only can enter. Those above 60 years cannot enter because this scheme is there for a long time. They might have they should have joined early. That is the thing. And even up to 80 years, it continues. And the renewal can be done. That is the highlight of this scheme. See, beyond this, what PPLS is doing is, PPLS has got 3 guest houses in Tamil Nadu. One is the PPLS guest house at Chennai, JVL Plaza, Anna Salai, Tenambet. The 7 double rooms, each 1,300 per day for IMA members and 1,200 for PPLS members. And 1 4-bedroom where 2,000 per day for IMA members and 1,800 for PPLS members. And Chetpat guest house, Sankara Heritage Apartment, Spartank Road, Chetpat. There also we are having a room, 5 double rooms, each 1,416 per day and 1,300 for PPLS members. 1 single room, 710 per day for IMA members and PPLS members. And we need to contact the PPLS office, the lodge office at JVL Plaza. And another one is the PPLS IMA guest house. The good spacious rooms available, 1,200 for a double bedroom and 1,700 for suite. This also, they need to contact the IMA office. These are all the schemes that are available. And what are all the things you are having the doubts, you can ask me. And we also have our Pandit in this PPLS scheme, our Tirupati sir. He also will be able to answer our queries. So any questions you can start asking here.
Rajesh, actually, I am a PPLSS member since long time.
Okay,
And initially, the amount covered was only about 5 lakhs or something. Now they have
5 lakhs and
increased.
10 lakhs, sir. Initially, it was
No,
5 lakhs and
yeah.
10 lakhs only, sir.
Yeah,
Now
now
that
it
5
has
lakhs is
increased to
transferred
20
to 10
lakhs.
lakhs and 10 lakhs to 20 lakhs, sir.
In the present day of litigations, the amount is very less. Actually, it runs in sometimes in crores also, the compensation to be paid. So I think IMA should think of increasing the coverage, amount coverage, I think, for this PPLS. Because 20
Sir,
lakhs in the present day is very
actually
less.
we are discussing about it, what to do, sir. The same type of a scheme is available in the national IMA, sir. It is called National Professional Protection Scheme. In that scheme also, they cover only for 20 lakhs. But the difference between the national scheme and our state scheme is, that scheme, we need to pay every year the renewal amount we need to pay, sir. In that, for the 20 lakhs, when I was asking, sir, if we are having 1 crore, this one litigation, what to do, sir? The administrator of that National Protection Scheme, he told me, you take 5 schemes like that. That is 20,000, 20,000, 20 lakh, 20 lakh, 20 lakh ன்னு சொல்லிட்டு 5 எடுக்க சொல்றாரு அவரு. அதை எடுத்து வச்சுட்டு நீங்க வந்து அதை யூஸ் பண்ணிட்டு you can claim it like that if you are much worried about the thing அப்படின்னு சொன்னாங்க. அதனாலதான் even I am one of the district coordinators. In the PPLS meeting, I was discussing the same thing. We also will have a more like that அப்படின்னு சொல்லிட்டு I was asking them. But the order has not been passed. It is still in the stay only. Future we may be trying to do that.
Because of this, we are, forced to take even other insurance company policies. And because of this, because the amount is very low. In addition to PPLSSS, we are to take other insurance companies policy also.
Sir, that's what the disadvantage between the private and our insurance is. That's what I was telling, sir. In அதுலலாம் வந்து கேஸ் நடக்கிறப்போ அவங்க வந்து
I know.
immediately வந்து come for the coverage. That is the problem, sir. நம்ம இது வந்து எல்லாமே they will come and answer. இப்ப திருப்பதி சார் சொல்ல வந்தீங்க, சொல்லுங்க.
Okay, sir. Two things, sir. What I want to இங்க சொல்ல வேண்டியது என்னன்னா, if இது வந்து இப்ப ஸ்டாப் கேப் சொல்யூஷன் லாங் டேர்மா நான் புஷ் பண்ண வேண்டியது ரெண்டு விஷயம் which I want to propose here. One is we have vicarious responsibility இருக்கு. அதாவது நம்ம ஸ்டாஃப் நர்ஸ் என்ன தப்பு பண்ண நம்ம தான் பொறுப்புன்னு ஒன்று இருக்கு. ஸோ vicarious அப்போ வந்து 24 hours நம்ம இருக்க முடியாது. ஒரு எல்லாத்துக்கும் நம்ம பொறுப்புன்னு வர்றப்ப தான் implications are coming up. ஸோ இதை எப்படி நம்ம மீட் அவுட் பண்ணலாங்கிறது ஃபர்ஸ்ட் பாயிண்ட். செகண்ட் திங் ஐ ஜஸ்ட் கமிங் டு காம்பன்சேஷன் பாயிண்ட். ஃபர்ஸ்ட் பாயிண்ட் இஸ் எவ்ரி லா லீகல் ஹஸ் சம் ஹிஸ்டரி. vicarious ரெஸ்பான்சிபிலிட்டி எங்க இருந்து வந்துச்சு அப்படின்னு நம்ம பார்த்தோம்னா, ஒரு காலத்துல வந்து அடிமைகள் ஸ்லேவரி வந்து உலகத்துல இருந்தது. ஸ்லேவரி வாஸ் ஈவன் லிஸ்டட் ட்ரேட். இட் வாஸ் a listed trade. அப்ப ஸ்லேவரிக்கு கையில பணம் கிடையாது. ஸோ ஸ்லேவ் ஏதாவது தப்பு பண்ணானா மாஸ்டர் ஹேஸ் டு பே. இதுதான் ஹிஸ்டரி ஆஃப் vicarious ரெஸ்பான்சிபிலிட்டி. அது சம்பந்தமே இல்லாம நம்ம கொண்டு போய் மெடிக்கல் காம்பன்சேஷன் கொண்டாந்து வச்சிட்டோம். If we are saying that vicarious responsibility holds, we agreeing that slavery is there in India. It's not slavery here. So இந்த விஷயத்தை நம்ம ஆர்கனைசேஷன் IMA இதெல்லாம் கொண்டு போய் vicarious responsibilityங்கிறது it is stems out of the slavery trade, not out of anything. அதை இங்க பொருத்தி வச்சது நம்ம தப்புங்கிறத we should create a legal entanglement to come out of it. This is first my proposition. Let us understand that first thing. ரெண்டாவது விஷயம், இப்போ இந்த காம்பன்சேஷனை கூட்டிகிட்டே போறப்ப நம்ம ஊரை பொறுத்த வரைக்கும் என்ன ஒரு பிரச்சனை அப்படின்னா, we go by sentiments. அதாவது ஆக்சிடென்ட் நடந்துச்சுன்னா எது பெரிய வண்டியோ அதான் தப்பு அப்படிங்கிற மாதிரி we have sentiments in this. அப்படிங்கிறப்ப what happens is ஃபியூச்சர்ல நம்ம நிறைய எல்லாருமே இன்சூரன்ஸ் பண்ணு ஜட்ஜுக்கெல்லாம் தெரிய வர்றப்ப என்ன ஆகும் அப்படின்னா, MCOP மாதிரி நீங்க தான் இன்சூரன்ஸ் பண்ணிருக்கீங்களே அப்படின்னு சொல்லி ஜட்ஜ்மெண்ட்ஸ் ஈஸியா வழங்கிட்டு போயிடுவாங்க. உங்கள்ட்ட பணம் 1 கோடி ரூபாய் பண்ணிருக்கீங்களே, you have 1 crore, you have 2 crores, so why not you give. நம்மளும் என்ன பண்ணுவோம், சரி ஏதோ பண்ணிடலாம் கொடுத்துட்டு போயிடுவோம். அது என்ன ஆகும்னா, ஒரு ரோட் டிராபிக் ஆக்சிடென்ட் இது மாதிரி வித்தவுட் எனி ஆர்குமெண்ட் வேலிடேஷன்ல சிம்பத்தட்டிக் கிரவுண்ட்ல வாட் வில் ஹேப்பன் இஸ் they will award some amounts. ரெகுலர் பேஸில் நடக்கிறதுக்கு வாய்ப்பு சீக்கிரமே இருக்கு. ஸோ திஸ் இஸ் வெரி வெரி இம்பார்ட்டன்ட், வெரி 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 டேஞ்சரஸ் சிச்சுவேஷன். அப்போ என்ன ஆகும்னா, நம்மளுக்கு வந்து நம்மளுடைய ஒவ்வொரு கம்பெனி என்ன பண்ணுவாங்க, 2 கோடி பத்தாது சார், 4 கோடி நம்மளுடைய இதை போறப்ப நம்ம என்ன பண்ணுவோம், we put on the patients. So cost of healthcare also goes. This becomes a vicious cycle which is not looking back. So what we have to pitch for here is capping of compensation. Capping of compensation we have to pitch for. See, நம்ம பேஷண்ட் அவங்க எப்படி கணக்கு பண்றாங்க, அந்த பேஷண்ட் எவ்வளவு சம்பாதிப்பான் அப்படின்னு வச்சு காம்பன்சேஷன் கால்குலேட் பண்றாங்க. நம்ம ஃபீஸை வந்து அவன் எவ்வளவு சம்பாதிக்கிறான்னு வச்சு கணக்கு பண்ணலையே. ஒரு பேஷண்ட் எவ்வளவு நம்ம அவனை பொழைக்க வச்சோம்னா எவ்வளவு சம்பாதிப்பாங்க அப்படின்னு நினைச்சு நம்ம ஃபீஸ் வாங்கல. நம்ம ஒரே ஃபீஸ் தான், காம்பன்சேஷன் தான், ஒரு கேப்போட தான் வாங்கிக்கிறோம். அந்த மாதிரி we have to pitch for capping of compensation. அப்பதான் இதுக்கு தீர்வு வருமே ஒழிய, otherwise it's going to increase 2 crores, 5 crores, 6 crores போயிட்டு தான் இருக்க போகுது. And judgments going to be very easy. Judgments going to be very easy for them. ஏன்னா சிம்பத்தட்டிக் கிரவுண்ட்ல சார் தப்புன்னு தெரியுது சார், உங்க மேல தப்பு இல்லை, அதை இன்சூரன்ஸ் பண்ணி நீங்களா கொடுக்க போறீங்க சார், பாவம் அவன் ஒரு 10-20 லட்சம் வச்சுட்டு போறாங்க சார். ஸோ அது வந்து ஆர்டர் ஆஃப் த டே மாறிடும். அப்புறம் we cannot look back. This is second issue. Third issue, what I want to say to IMA everything is, இப்போ நம்ம வின் பண்ற ஒரு கேஸை வின் பண்ணதுக்கு அப்புறம் நம்ம வந்து நம்ம மன உளைச்சலுக்கு we have to sue the patient back. நம்மளுக்கு சார்பா தீர்ப்பு வந்துருச்சுன்னா, எனக்கு மன உளைச்சல் ஆளாக்கிட்டாங்க அப்படின்னு நம்ம we are entitled to sue. அப்படிங்கிறப்ப தான் பேஷண்ட்டுக்கு ஒரு பயம் வரும், என்னன்னா நம்ம தப்பான கேஸ் போட நம்ம மேலேயும் கேஸ் வரும்னு பயம் இருக்கு. நம்ம எல்லாரும் என்ன பண்றோம், நம்ம ரிலீவ் பண்ணிட்டோம்னா அதோட we come out of the situation. Once நம்ம மேல தப்பு இல்லைன்னு எவ்வளவோ கேஸ்ல ப்ரூவ் ஆறப்ப we have to take the case further. IMA stands to take the cases further. Can I talk?
Sir, one minute, sir. We will put the first question.
இதை மட்டும் முடிச்சேன், அவ்வளவுதான், ஒரே பாயிண்ட்.
ரைட் ஓகே
அதாவது அந்த ஃப்ளோ போயிடும் சார், கோச்சிக்காதீங்க. அதனாலதான்
ரைட்
ஸோ நம்மளும் சிவில் கேஸ் உள்ள போட்டோம்னா நம்ம வந்து பேஷண்ட் ஷுட் நோ தட் நம்ம தப்பா கேஸ் போட்டோம்னா நம்மளும் நம்ம காம்பன்சேஷன் கொடுக்குறாப்புல இருக்குன்னு தெரியும். பிகாஸ் we are entitled which we are not using it. So இந்த 3 விஷயத்தை I want to propose here to take it further. Thank you sir.
ஸோ மெயினா வந்து இப்போ என்னென்ன பாயிண்ட் சொல்றீங்க? நம்பர் 1 வந்து என்ன சொல்றீங்க?
Vicarious responsibility. ஏன்னா ஸ்டாஃப் நர்சஸ் ஆர் பீங் பெய்ட். அவங்க பண்ற தப்புக்கு அவங்க தான் பண்ணணும், நம்ம எடுத்துக்க முடியாது. ஏன்னா இட்ஸ் செம்ஸ் ஆஃப் ஸ்லேவரி. ப்ளீஸ் அண்டர்ஸ்டாண்ட். கம்ஸ் ஆஃப் ஸ்லேவரி. ஸ்லேவரி
எப்படி கரெக்ட் பண்றது? அதை எப்படி கவர் பண்றது?
அது அவங்க let them cover. ஏன்னா we are staff nurses are paid. Vicarious responsibility ஹிஸ்டரியே என்னன்னா ஸ்லேவ் கையில பணம் கிடையாது. அதனால மாஸ்டர் has to give. Staff nurses are no more. We are not masters of the staff nurses here.
சார் நர்சிங் கவுன்சில்னு தனியாவே இருக்கு. ஃபார்முலேட் பண்ணணும். அவங்க ஃபார்முலேட் பண்ணி அவங்க வந்து இண்டெமினிட்டி பே பண்ணணும்.
அவங்க பண்ணிக்கலாம். ஏன்னா நம்ம தேவையில்லாத பர்டன் நம்ம சுமக்கிறோம். ஃபர்ஸ்ட் பாயிண்ட். This is one point. Number 2 is capping. We have to pitch for capping of compensation. Capping of compensation. இல்லைன்னா காம்பன்சேஷனை வந்து ஒரு ரொட்டீனா ஆக்கிடுவாங்க. சும்மா இந்த யார் கேஸ் போட்டாலும் 10 லட்சம் இன்சூரன்ஸ் ஆக்கிடுவாங்க. கேப்பிங் ஆஃப் காம்பன்சேஷன். 3வது ஏதோ ஒரு கேஸை நம்ம ஜெயிச்சோம்னா we win over the கேஸா இருந்தா அந்த கேஸை ஃபர்தர் பண்ணி we have to get a token compensation, at least token compensation for the patient so that he has sued me. இதை 3ஐயும் பண்ணாதான் லாங் டேர்ம் ப்ரொஃபஷன்.
இல்ல இப்போ இந்த விகேரியஸ் ரெஸ்பான்சிபிலிட்டிக்கு வந்து அவங்கள வந்து பண்ணணும்னு சொல்றீங்களா? அது எப்படி வரணும் பண்ண வைக்கிறது அவங்களுக்கு? நம்ம லீகல் என்டைம் நம்ம வந்து லீகல் என்டைம் உருவாக்கணும். விகேரியஸ் ரெஸ்பான்சிபிலிட்டி எங்க உருவாச்சு? அவங்க எனக்கு அடிமையா வேலை செஞ்சாதான் விகேரியஸ் ரெஸ்பான்சிபிலிட்டி. அவங்க அடிமை கிடையாது. நீ ஹிஸ்டரி எடுத்து புக்ஸ் எடுத்து பாத்தீங்கன்னா விகேரியஸ் ரெஸ்பான்சிபிலிட்டி வந்தது ஸ்லேவரில இருந்து வந்தது. அது தேவையில்லாம நம்ம காம்பன்சேஷன் வச்சிருக்கோம். அதை நம்ம யாரும் ரைஸ் பண்ணவே இல்லை சரியான முறையில். யூ ஹேவ் டு ரைஸ் இட் ப்ராப்பர்லி. See 24 hours நீங்க ஒரு இன்ஜெக்ஷன் தப்பா கொடுத்தா நீங்க தான் பொறுப்பா இருக்கீங்க.
No, should IMA file a case in the court to?
Yes, we should file a case. We should escalate. Create a legal entanglement. நம்ம வந்து அவங்களை எதிர்த்து சொல்லல. நம்ம ப்ராப்பரா அகாடமிக்கலா போறோம். ஸ்லேவரி இந்தியால ஸ்லேவரி இருக்கா? இல்ல. அப்புறம் ஏன் விகேரியஸ் ரெஸ்பான்சிபிலிட்டி வீடியோ ஃபிக்ஸ் ஹியர்? ஆனா எங்க விகேரியஸ் ரெஸ்பான்சிபிலிட்டி வரலாம்னா இப்போ ஹாஸ்பிட்டல் இஸ் பேயிங். யாராவது அந்த இடத்துல வேணா விடலாம். இப்ப நான் பெய்டு சர்வெண்டா இருக்கிறாங்கன்னா ஹாஸ்பிட்டல் வில் டேக் ரெஸ்பான்சிபிலிட்டி. இப்ப நம்ம பல பேர் ஃபீ ஃபார் சர்வீஸ்ல இருக்கிறப்ப எப்படி ரெஸ்பான்சிபிலிட்டி எடுக்கணும்? அண்ட் டாக்டர்ஸ் கேனாட் பி ரெஸ்பான்சிபிள் ஃபார் மிஸ்ஹேப்பனிங். ஒரு ஸ்டாஃப் தப்பா இன்ஜெக்ஷன் கொடுத்தா நம்ம ஏன் தப்பா எடுத்துக்கணும்? நம்ம ஏன் எடுத்துக்கணும்? அவங்களுக்கு பொறுப்பு இருக்கணும்ல. அவங்களுக்கு தேவ் பீன் பெய்ட் அடிக்வேட்லி. இப்ப லேபர் கோர்ட்ல அவங்களுக்கு சொல்றாங்களா லேபர் லாலாம் அவங்க பண்ண மாறி போச்சு இல்ல. நம்ம இந்த பழைய இதை வச்சுக்கிட்டு இங்க பொறுத்திக்கிட்டு இருக்கோங்கிறது என்னுடைய கருத்து. We have to escalate. அது பத்தி டிஸ்கஷனா வந்தப்பதான் ஓரளவுக்கு அதுல ஒரு கிளாரிட்டி வரும். ஒண்ணு.
ரெண்டாவது வந்து இந்த கேபிட்டல் கெயின் காம்பன்சேஷன் சொன்னீங்க.
கேப்பிங் ஆஃப் காம்பன்சேஷன். காம்பன்சேஷன் இவ்வளவுதான் இருக்கணும். மெடிக்கல் காம்ப்ளிகேஷனுக்கு இவ்வளவுதான் கேப்பிங். 10 லட்சம் தான் மேக்ஸிமம் இருக்கணும் வைக்கணும். நீங்க எப்படி கனெக்ட் பண்றாங்க? ஒருத்தன் இறந்து போனானா அவன் எவ்வளவு சம்பாதிப்பான், அவன் எவ்வளவு மல்டிப்ளை எவ்வளவு வாழ்நாள்ல சம்பாதிப்பான்னு கணக்கு பண்றாங்க. அப்ப நம்ம ஃபீஸ் வாங்குறது அப்படி வாங்கலையே. ஒருத்தனை காப்பாத்தி உயிரை
அதை எப்படி நாம மாத்துறது?
based on the charges what we charge on the patient.
அப்படி சொல்றோம். பேஷண்ட்டுக்கு சார்ஜ் பண்றத வந்து நம்ம வந்து அவன் எவ்வளவு உயிரை பொழைச்சி அனுப்பிச்சோம்னா நம்ம இவ்வளவு சம்பாதிப்பான்ல, அப்ப எனக்கு ஒரு பங்கு கொண்டு கேட்கலாமா? கிடையாது இல்ல. நம்ம ஒன் ஆஃப் த ட்ரேடா பாக்குறோம், ஃபீஸ் வாங்குறோம், அதோட முடிச்சுக்கிறோம். ஆனா when it comes to compensation, they calculate அவன் உயிரோட இருந்தானா இல்ல எபிலிட்டியோட இருந்தானா எவ்வளவு சம்பாதிப்பா, எவ்வளவு சம்பாதிச்சானா அதை நீங்க கொடு அப்படின்னு கேட்கறது. நம்ம அப்படி கணக்கு பண்ணி ஃபீஸ் வாங்குறது இல்ல. சோ இதையும் நம்ம டிஸ்கஷன்ல கொண்டு வரணும். We have to discuss. அதாவது நாளைக்கு தீர்வு வராது. பட் இந்த டிஸ்கஷன் அவேர்னஸ் we have to come out of it. We have to come out of it discussion and say that we have to let us cap the வேண்டாம்னு சொல்ல அவனுக்கு உரிமை இருக்கு. நம்ம எப்படி ஃபீஸ் இவ்வளவுன்னு நம்ம வச்சிருக்கோமோ we don't have a surge pricing வைக்கிறது இல்லையே. நம்ம we don't have a surge pricing. அப்படிங்கிறப்ப காம்பன்சேஷனுக்கு ஒரு கேப்பிங் இவ்வளவுதான் மேக்ஸிமம். 10 or 20 lakhs இந்த கேஸுக்கு இந்த கேஸ் இவ்வளவு கேப்பிங். யூ cannot escalate for. அப்ப ஒரு ஏழையா இருக்கிறவன் செத்து போனா கம்மி. இப்ப இந்த பாயிண்ட் தான் வைக்கணும். ஏழையா செத்து போனா அவனுக்கு கம்மியா கொடுக்கலாம். அப்ப you divide the society accordingly. அப்ப why can't doctors also divide the society accordingly? We have to create this legal entanglements academically, not as a இது. We have to create as a academically.
So capping is available in some countries. It's not available in India, but in some countries, capping of medical legal compensation is available.
அத பத்தி நம்ம எப்ப மீட்டிங் உட்கார்ந்து ஐஎம்ஏல வந்து பாராட்டிட்டு வந்தறமே ஒழிய இந்த மாதிரி விஷயத்தை டிஸ்கஸ் பண்றதே கிடையாது நம்ம ஆர்கனைசேஷன்ல.
Probably சார் நாம இதெல்லாம் டிஸ்கஸ் பண்ணுவோம்.
கைடன்ஸ் எடுக்கணும். அந்த கண்ட்ரில எப்படி கேப்பிங் பண்ணாங்க
சார் நாம இந்த மாதிரி எல்லாம் பாயிண்ட்ஸ் எல்லாம் வந்து வெளியில ரைஸ் பண்ணி நம்ம we will go forward சார்.
ஃபார்வர்ட்னா
it's not the end of the game because people வந்து மத்தவங்க எல்லாம் இருக்குறவங்க ஆல்ரெடி ஆபீஸ் பேஸ்ல இருக்குறவங்க they are not doing it.
To be honest ராஜேஷ் சார், இத பல இடத்துல வந்து I have escalated in IMA also, but nobody hears. They want to scratch their backs. அவ்வளவுதான். I scratch your back.
Sir, we will do it.
Awards. You give awards and come out. They give awards and come out. But இந்த மாதிரி டிஸ்கஷன் பண்ணவே இல்ல. ஃபர்தர் பண்றதே இல்ல. நான் டிஸ்ட்ரிக்ட் கோஆர்டினேட்டர் தான் இருக்கிறேன். நான் எஸ்கலேட் பண்ணாலும் அத பத்தி சீரியஸா யாரும் எடுத்துக்கல.
இல்ல next time we will have it. நீங்க நெக்ஸ்ட் மீட்டிங் எல்லாம் வாங்க நாம ஃபர்தரா டிஸ்கஸ் பண்ணுவோம்.
Third thing, நம்ம ஒரு கேஸ்ல ஜெயிச்சோம்னா IMA PPLSSS has to
இல்ல அது நாம பண்ணுவோம் சார். அத வந்து நாம நெக்ஸ்ட் மீட்டிங்ல அத இது பண்ணி
பேஷண்ட் என்னப்பா நம்ம தப்பா கேஸ் போட்டோம்னா நம்ம குடுக்கறதா இருக்குன்னு நினைச்சாதான் ஃபால்ஸ் கேसेस ஃப்ரிவலஸ் கேसेसலாம் வராம இருக்கும். அதர்வைஸ் அவனுக்கு ஒரு லாஸும் கிடையாது. ஃப்ரிவலஸ் கேஸ் நான் பாட்டு போயிட்டு போவேன், வந்தா இல்லைன்னா வந்தா காசு வரலன்னா சும்மா இருப்பேன்னு இருக்கிறது. அவன் தப்பா போட்டிருந்தானா ப்ரூவ் ஆச்சுன்னா நம்ம காம்பன்சேஷன் கிளைம் பண்றாப்புல இருக்கும். அப்பதான் அவங்களுக்கு பயம் வரும். அப்பதான் அது பயம் இல்ல, ஒரு நெறிப்படுத்ததா வரும்னு என்னுடைய கருத்து. இந்த மூணையும் தான் I am keeping on talking, but I don't think nobody listens about that. Everybody giving awards and ponadis. அவ்வளவுதான். This is my criticism.
I have a point to add.
Girish sir, come on sir. Girish sir, sorry.
I just looked up the caps available now. Apparently in 30 states in US there are caps. We need to look at these examples in other countries and then see what we can do about it. I just shared one link. I'm sure if you do a web search, we can find more information.
Sir, we will write some discussion points which were discussed here and send a letter to IMA, sir.
Yeah, that's
and
good.
Then we will see what they are doing it, sir.
Can I just add
from
some
our
point?
Association, we will write.
Can I just add some point, Dr. Rajesh?
Yes,
sir.
Well, I think Tirupati has been very aggressive, Dr. Tirupati.
Not aggressive, sir. That's putting my point.
Well, I think there is, in all notifications, you are very done notification with the compensation and all that. And you said the compensation has been calculated. You look up to the highest compensation that has been awarded is Dr. Kunal Saha, the case in Kolkata. And if you look into that, it is available in the public domain. And you can actually see how the calculation is being done, how that complainant has defended himself, not defended, how he has brought out what you can say, all the details. It's very nice to read that actually. And in that also, the vicarious responsibility for the hospital also is there. 6 crores. He asked for 77 crores. 6 crores or up to 9 crores or something was awarded. 50% was the hospital, 50% only for the doctors. And doctors, that is one of the chief doctor along with the dermatologist. So you find this calculation was done not by the Supreme Court. They gave the judgment and they passed it forward to the National Commission. They only did the calculation. So to them, we might not again apply for a capping. That is one. The other very, very important thing, which I have been actually, analyzed in detail, this one of the study, in Thoothukudi, where a doctor was murdered, a lady doctor. I'm sure all of you know about it. And about 2 years later, there was an analysis done in the public asking what could be the probable reason and why this has happened, why that person was murdered. And when it was asked, came the conclusion that communication was not good. They were not talking very well. They were rude. And you find even the obstetrics of gynecology society, they have also brought out to the conclusion that doctors' communication with the patients is not much. Somewhere, I think we have to think about ourselves too. Are we doing the right thing? No, we can put the blame on the patient. We can be aggressive. We can do so many things. But we have to have a little of self-introspection to find out, are we doing the proper thing? This has got to be. That is why today in MBBS, right from the first year, they are teaching the communication. That too, the Kalamazoo in North Michigan. You find 27 medical educationists descended globally and discussed and found that communication has to be improved in the medical profession. And that is what now the NMC has introduced right from the first year curriculum in the form of role play communication, right from the first year to the final year.
Sir, the communication is always a dicey thing. We always see you talk to them in their vernacular language with all the attenders in place. You clearly explain. At the end of the procedure, they again said, "Sir, ella undu thane, onnum prachane illalla." So this is very difficult. Even if you do a video recording, people will say they didn't understand anything if something goes wrong. If everything goes right, they say everything was good. The doctor was very good. He is like a god. Otherwise, if something goes wrong,
and we always have
enemies. Could understand.
I tell you, a doctor doesn't have enemy outside. A doctor has enemy only within. It is one of our colleagues who points out and tells that something has gone wrong.
Yes, yes, sir. I agree with you.
And when they are asked to put it down in writing, they'll say no. Is it? I'm here in this field for 40, 45 years, and I know exactly.
Yes, sir. As you rightly said, most of the litigation are from the victims of doctors. Please understand. Including Dr. Kunal Saga case, the victims of doctors. Please understand. Most of the high compensation cases are victims of doctors. That itself says the things. And I think that's what Rajesh said, that we can address these issues academically, right to IMA, so that we move forward in a direction where we have a conducive atmosphere, rather than having temporary solutions, increasing the compensations, increasing the premiums like that. Please.
But the amount is very low. 20 lakhs is very, very low. I think PPLS has got to increase, as what Dr. Rajesh is telling. It has to be increased.
One important thing about PPLS is, even if it is awarded, I mean, if the court has said you are culpable and they have awarded a compensation, if you are sure that there is no negligence or nothing wrong in your side, PPLS will again defend it in the higher courts, which the private insurance companies will not do. They will
That
go
is the
for
difference
out-of-court
between the
settlement.
private indemnity bonds and our PPLS, sir. Very, very important thing, sir. And that we should appreciate. And only thing is, we were going on asking about increasing the amount, sir. But for increasing the amount, the premium also has to be increased. Even for this 20 lakhs, the premium, how much is coming for 5 years? It is 20,000 rupees, sir. They will not be paying, sir. That is the main thing.
Sir,
if you increase more.
Rajesh, sir, compensation capping panta the prachane illa, sir.
I think that's a very good idea.
That is not, sir, easy. Otherwise, it's going to increase. Inflation. Correct. Compensate, we have to pitch for strong. Everybody thinks that, okay, money is there. That's, please understand. That is my point I'm stressing here. If you are going to increase that, that gives a way for judge to proclaim easily. We are giving more easy atmosphere.
The best way is
what you have to pitch strongly is capping of compensation, which exists in many countries. Please, let us not. It is totally two different directions.
Probably, like Dr. Murugan sir said, we have to take the international way, how people are capping it and what methodologies they have used to cap it. The same thing we may have to copy and modify according to the Indian needs and put forward through IMA to the National Commission. That is the best way to do, because most of the time the commission will ask, where else has been these things has been followed. So once we give the substantiations, things may be easier to push forward.
So otherwise, the insurance companies, they will lobby. So they will increase through you. If there is a copy of compensation, I think it's a relatively a fair atmosphere to.
Sir,
even in case of an air accident or a
sir, 1 minute, sir.
accident,
1 minute, sir. We will run these 3 questions and then we will discuss, sir.
Sure.
Number 1 question. Tubular spinal endoscope angle. This is the question number 1. You can answer for this. Now you can put the second question. Foramen of Monroe identified by confluence of A, B, C, D. Which is the option you have to tell?
சார் ஏகப்பட்ட ஸ்பெல்லிங் மிஸ்டேக் இருக்கு.
ஆமா இவங்க தான் டைப் பண்ணிருக்காங்க. அவசர அவசரம்
Monroe,
பண்ணிருக்காங்க.
MONO.
Okay, now the question number 3.
Monroe வந்து இருக்கா.
Okay, we can start discussing. We will get the winners by the.
அது முருகன்
Okay,
சார்.
start.
முருகன் சார் right?
Yeah, what I was trying to say was, even in case of air accidents, rail accidents and all that, the compensation is not paid on how much salary the person was getting or what was his net worth or anything. There's always a fixed amount for it, even if the accident is due to negligence, pilot error, or airline error, or repair engineering error. So when there can be a cap on that, we have to quote all these examples. In other industries, we have to quote, in other countries, we have to quote, and we have to try to get this.
So one drawback in this scheme is that is they are giving the limitation to Tamil Nadu only. That is the only thing, sir, that we need to discuss among the people, and then we should make that even if it is from the other state also, we need to, if they are coming, we need to take up and do it. That's what.
That is a valid problem, because some of us work in hospitals where most of the patients are from a different state. And if there is a
that's why,
litigation
sir,
coming from a different state, they refuse to take up the case. But in the recent
That's
IMA
what-
meeting, when there was a
that is-
PPLSSS meeting
sir,
organized,
that is one thing, sir. That is one
Yeah.
thing. The another thing is only from the doctors in Tamil Nadu, if they are practicing only in Tamil Nadu, they can take. For example, if if a doctor is practicing in Valayar, which is on the border of Coimbatore, that is just 5 kilometers from Coimbatore, and they cannot take up it. Take this PPLS, even though they are the members of the IMA Tamil Nadu. And the same way, the people who are practicing in Pondicherry, for example, one of my friend is working as an anesthetist in Jipmer. He was working only in Tamil Nadu, and subsequently he got a job there, and he was practicing there. And now, if he commits if any case comes on him, it may not be covered. That also we need to clarify, and we need to modify some of the things in our PPLS, sir, actually.
Sir, how about national PPLS? Does it cover all over India, or
National covers throughout the India, and only drawback in that scheme is the 20 lakh compensation is there maximum, and you need to pay every year. That is the main thing. Every year you need to renew, and every year only 200 rupees only reduced for the next subsequent years. That is the only thing. And what they are saying, if you want to take more than 40 lakhs, 60 lakhs, you take 2 schemes, 3 schemes, like that they are telling the person who is in charge of it.
Now, how much
was
is
the founder.
how much is the payment, sir, every year?
I will see that and tell, because I am
No,
not
if it
having
is
a by heart.
equally divided, then we can go for that only. No, why we should?
No, that also you can have it. That also you can have it, sir. But actually, I need to check it up, and I will put it up
Okay.
in the groups, actually, because
Yeah, we should stop. What is that? Okay. Try not to get into the problem.
problems are not coming just like that. It is all our fate. That's all. Suffer ஆகணும்னா suffer ஆகுது, அவ்வளவுதான். One minute இருங்க, நான் அது பார்த்து சொல்றேன். இப்பவே
I'm
சொல்லிடுறேன்.
just asking you, because learned people are here. I'm just asking you. So many litigations, so many people are getting into trouble. and the courts and everybody is expecting more expertise from the doctors. But at the same time, the government of India, union government, and the TamilNadu government is opening so many colleges. Do you think the people comes with the degree can withhold all this nonsense? I don't know what's going to happen in future. In
Sir.
one side, people are expecting more. Other side, everybody wants to become a doctor, and even whether somebody has a knowledge or not, for the sake of caste or for the sake of the community, they want to become a doctor, whether they have a knowledge or not. Samuga Nidhi. What's going to be the future? I'm just asking. I'm really wondering what's going to happen in future.
Survival of the
political.
fittest.
Hmm?
Survival of the fittest.
No.
Sir,
Who is
only thing you were asking about
Patient.
that national scheme, no, sir. I am having it straight away. I got it. That is the first year membership is 3,000 rupees for a compensation of 20 lakhs. So what they are telling, the second year membership is 100 rupees less, like it is going on. And
No, 100 rupees less means 2,900.
2,900 on the second year for the same 20 lakhs. For 20 lakhs, they are asking only 3,000 rupees per
But
year you need to pay. That
But
is
in
the thing.
Tamil Nadu,
Through
for 5 years,
Tamil Nadu for 5 years, 5-year scheme for 20 lakhs, it is 20,060 rupees.
so it's equal, no?
It's actually cheaper.
No, no,
Looks like
the
it's
difference
cheaper.
be-
Cheaper
no,
actually.
The difference between the
It is cheaper.
state and national scheme is they give the lawyers of the PPLSSS give the reply, frame the reply, everything, but which is not done in the national.
That is the difference. And another thing,
I don't know. What's the difference?
finally,
What is the difference?
The state PPLSS provides a legal team who will go through your case sheet that you submit, and they themselves will prepare a reply. You don't need to employ a separate lawyer.
What
These
about the national loan?
Apparently, Dr.
national, they
Ramesh
are
is saying it is not there.
straight away, they will only lawyer only will be dealing it. The legal team will not be giving. That is the difference. And another thing, what they have given, enhanced protection scheme. The financial assistance of up to 1 crore rupee membership fee, they have put it as 10,000. That is also there. This is for your information.
Okay.
Already they are having one thing which is for 1 crore. The national protection scheme, they are giving 10,000 rupees only for the premium per year. It is called enhanced protection scheme. That is
Okay.
also there.
So let's have the answers to the quiz and wind up.
Yeah, please.
So for the first question, who is the winner? The answer is the first question. The answer is the tubular spinal endoscopic angle is 25 degrees, and the winner is Dr. Trinath. Trinath is available.
Yes, sir.
You are from which
Yes, sir.
institution?
From Chettinad Hospital, sir. Chettinad Hospital and Research Institute, sir.
Huh?
Chettinad Hospital and Research Institute, sir. Chettinad.
Very nice. Welcome. Congratulations.
Thank you,
Congratulations.
sir.
So for the question number 2, foramen of Monroe identified by confluence of. Answer is A, septal vein, thalamostriate vein, choroid plexus. And the winner is Dr. B. Sivasubramanian. Dr. B. Sivasubramanian available?
Good evening, sir. I am from Madurai Medical College, sir.
Which year?
Final year, sir.
Congratulations, winner.
Thank you, sir. Thank you, sir.
You should mobilize all the PGs to attend all the programs, man.
Okay,
Because
sir.
the
Sure.
number of people who have attended here, actually we have got 143 PGs, but hardly only 20-25 PGs only joined. The rest of the people are all IMA doctors, mostly I think, today joined. That is the main thing. You should mobilize more of your PGs. At least you should see your institution PGs should attend this program.
Yes, sir.
How
Sure,
much
sir.
pains we are taking to do it. Very difficult, man. Then
Okay,
question
sir.
number 3, ETV is done anterior to, the answer is that mammillary bodies, and the winner is Dr. TamilNadu from TamilNadu available? TamilNadu
Sir, good evening, sir.
from which institution?
M.ch Mission Hospital, sir.
M.ch Mission Institution. Congratulations.
Thank you, sir.
So congratulations. Okay. So these are all the 3 winners, and they will be awarded. And any other thing you want to discuss, anyone? Sir, actually, President.
Sir, kindly unmute and speak, sir.
President, sir, one request to
Yeah,
you,
tell
sir.
me. Yeah, tell me.
You prepare prepare about this meeting, what happened for the PPLS like that, and you give a write up, and we will send a write up to the Indian Medical Association along with Tirupati sir. We will create a new agenda, and then we will submit it to the IMA for the state and also to the nation. Also, we said.
Sure, Dr. Tirupati and me will work on it with help from everybody else.
Thank you.